लाइव कर रहे हैं, कंफर्म कर रहे हैं सर.
Okay, Anirban, if you can switch on your audio.
Good evening, sir.
Good evening, everyone. Very good.
सर फेसबुक लाइव स्टार्ट हो गया.
Okay.
थैंक यू.
Namaskar. My name is Dr. Alok Roy from Medica Superspecialty Hospital, Kolkata. We, in our series of webinar, which we conduct every Saturday and Sunday, we conduct in 3 places, from Ranchi for the Hindi speaking, from Siliguri for North Bengal, and on Saturday 5:30 to 6:30, we join you for Calcutta and for the our neighboring region. We bring this webinar to enlighten you with what can be done in your day-to-day life to stay healthy. And today, being a Basant Panchami and being a Saraswati Day Puja, I thought we must remind us that, as they say in Upanishads, Asto ma sadgamya, tamso ma jyotirgamya, mrityorma amritamam gamya. That means lead us from the real, unreal to the real, lead us from darkness to light, lead me from death to immortality. What could be a better day than to share the knowledge with you all on Saraswati Puja? We bring this to you for you to stay healthy. We don't want to come to the hospital. We want you to take care of yourself. Today, we are very fortunate to have Dr. Anirban Chatterjee. He is a very famous hand surgeon and trauma surgeon from Calcutta with us. He has been with us for the last 10 years and has performed hundreds of surgeries. One of the commonest cause of trauma and the elderly, the trauma-related joint replacement is a hip injury, where the hip joint or hip bone gets affected. Without wasting time, I would request Anirban to introduce himself and start his presentation, that how can we keep you healthy. So he'll talk to you about hip trauma, its causes, treatment, and prevention. Over to you, Anirban.
Thank you, sir. Good evening, viewers and all our listeners who have tuned in. Today's topic for discussion is about hip fractures. So without much ado, we shall go and start with that. So the brief was to basically talk to you all about what are the circumstances which lead to the fracture of the hip bone, what are the possible preventive strategies which we can adopt, and what are the management options. So if you know, how does the hip bone break? The hip is a very strong bone and it doesn't break very easily. So if the bone is healthy per se, then it requires a lot of force, which means a high energy trauma is necessary for it to break. On the other hand, if the hip bone per se is a little unhealthy, then a little bit of a trauma, and which is characterized as low energy trauma, may be sufficient for it to break. Now, what are high energy trauma? Well, when we talk about high energy trauma, the commonest are motor vehicle collisions, or a fall from a motorbike or a two-wheeler, or a fall from the stairs, or a fall from a height. Now, a lot of these injuries happen because of lack of proper policing on the highways, very signals which may be jumped, or sometimes because of rash driving. And often the persons within the vehicle as well as the pedestrians can get injured. On the other hand, low energy trauma is something which happens very commonly, and this is one of the commonest patterns which we come across. An elderly person who goes to the bathroom, maybe in the middle of the night, and slips and falls, or the person trips over a wet floor and falls down, or falls down a pair of stairs. Now, all of this may be related to there will be multiple factors involved in that. So, as a person ages, they have some problems with vision. So, the spectacles may not be adjusted properly. You may be using bifocal. So, when you look down, you're not properly adjusted. The floor may be smooth and shiny. It may not have the grip that is required. There may be a little bit of water on the floor, which goes unnoticed. And some more often than not, we hear from our patients that in their urgency to go to the toilet, because with old age they have some issues with related to bladder control. In their urgency to try and get to the toilet, somehow they trip and fall. So these are the mechanisms of low energy trauma. Now, what do you mean by an unhealthy bone? Now, the commonest cause of an unhealthy bone means that the density of the bone per se has become less. So, one of the commonest things which we come across in elderly patients is osteoporosis, or what is known as low bone density. And here on the picture, you can see that the density of a normal bone, it's very well packed. Whereas in a bone with osteoporosis, you have a lot of these uh, holes opening up. So it becomes more porous and it is more prone to fractures easily. And therefore the bone becomes fragile. And some of these fractures are therefore called as fragility fractures. That means it occurs because the inherent nature of the bone has become fragile. Another condition which we commonly encounter is a condition called osteomalacia, and its corresponding entity in the pediatric age group, which is called as rickets. This happens mainly because of vitamin D deficiency, along with some calcium deficiency. And on X-rays, sometimes you can get these very small cracks, which are essentially stress fractures. So all the weight bearing which happens, the weight bearing axis goes along here, and these are the points where the stress is maximum and they tend to fracture, and these are the loser zone. And this is a type of a sort of a pathological fracture. As opposed to this, an unhealthy bone can also be because there is actually a tumor there, or a malignancy there, or even a non-malignant lesion may be present, and therefore this is classified as a pathological fracture. So here you can see an individual where there is a lesion which has literally eaten away the bone, and so this part of the bone becomes so soft and fragile that it breaks easily. Now, can hip fractures also occur in children? Well, this paper in 2009 showed that yes, it can happen, but it is definitely a very small percentage, about less than 1% of all pediatric fractures. The commonest being a fracture of the clavicle, which is the collarbone, or the fracture around the elbow. This is usually seen with high energy trauma, and it's often associated with other injuries. And if you see a fracture like this, here you can see that the whole neck of the femur is fractured, and it will require some sort of a intervention. On the other hand, it can also happen in some low energy situations where there is some pre-existing bone pathology, meaning the bone is inherently weak to start with. There are genetic conditions like osteogenesis imperfecta, where the bone formation itself is defective, and therefore the bone fractures very easily, not just in one place but in multiple places and on multiple instances throughout the life of the child, right from birth. Another situation is where there may be a bone cyst or a neoplasm within the bone. As in a situation like this, here you can see a small lytic lesion in the bone around the hip joint, and you can see where the fracture has occurred. Sometimes infection can also cause the bone to become very soft, and therefore they can also fracture in children.
Dr. Chatterjee, sorry to
Yes,
interrupt you. Can we go back to the previous slide?
yes, sir.
Can you just explain the lytic? What does lytic mean?
Uh, sorry, sir. A lytic lesion means where the pathology has actually caused lysis, meaning it has actually eaten away the normal bone. So if you look at this texture here, this is as if something has eaten out a little bit of that bone. Somebody has bitten a piece out of this part of the bone as compared to the normal texture of the bone here and here. Similarly, on the other view, you can see this is the part of the bone which is different in texture as compared to this area which is normal and this area which is considered normal. So these lytic lesions in the bone, they are often non-malignant, meaning non-cancerous in nature, but they inherently make the bone weak and prone to a fracture after a trivial injury. Can I proceed, sir?
Yes, please.
Yeah. So unfortunately, most of these fractures are such that they cannot be treated without any sort of a surgical intervention. Very rarely they can be treated in a plaster or a spica cast, which is a little cumbersome device and it has its inherent problems. So if an elderly person is made to lie down in traction for over 6 weeks or 8 weeks, which is the approximate time for which the bone takes to heal, there are a lot of associated problems that happen. So with the person lying in bed for at least 6 weeks or 8 weeks, unless there is very good nursing care, the chances of complications like orthostatic pneumonia, that means there is pooling of secretions in the lungs which get infected and you develop a chest infection. Similarly, lying in bed for a long time without proper change of posture can cause the persons to develop what is commonly known as bed sores or decubitus ulcers. Also, as the person will be forced to lie down for a long time in the sort of in a particular position, the blood circulation in the veins of the legs, they tend to clot up, and which is called as medically a deep vein thrombosis or a DVT. And if any of those clots dislodge from the legs, then it can spread either to the lungs or the heart and have catastrophic consequences. So the burden of care and the shift in treatment has moved worldwide to get the persons operated as early and quickly as possible so that the bone is either fixed with plates or screws or wires or whatever is deemed necessary, or in the eventuality where the head of the uh, femur is not viable to be preserved, then it is replaced either partially or totally, as is shown in the pictures on the right hand side. Now, this advantage of this surgery is that now that the bone is either fixed or replaced, one can start rehabilitation of the patient at the earliest, meaning the person can be made to sit up in bed, can be nursing care becomes easier, there is no cumbersome traction device which is attached, and the in-hospital care and the in-hospital time also can gradually reduce. Now, as you can understand, a 4 to 6 week period of rest or bed rest for any patient in today's day and era has huge implications to cost, not only about the cost of treatment, but also the cost to the society. And there have been multiple papers which have looked at this, which is the disease burden of the hip fractures worldwide. So if you look at this graph on the right hand side, these are the fracture burden which has been listed by the WHO as per the countries. And India is somewhere around here, not very high yet. But as we see, the more the developing countries, the more is the fracture risk. And it has been associated with the amount of osteoporosis as well. This was a study which was published from Europe, which showed that almost uh, the hip fracture, though they comprise about 20% of all the fractures, but the cost of the fractures was the maximum with hip fractures. So one can imagine that this burden of care which is required right from the time the patient fractures to the time the patient recovers is huge. And oftentimes, this fracture can be associated with disastrous consequences, meaning the mortality rate is also high, the morbidity rate is also high, and not all patients can go back to the previous, that is the pre-fracture level of activities in the society. I see there is a raised hand. Do we take the questions now or shall we do it after the presentation, sir?
We'll do it at the end.
At the end. Okay. So moving forward, what are the dangers? Well, the dangers are with respect to mortality, like I mentioned, the morbidity, the loss of function, and the quality of life of the individual, as also the quality of life of the entire family, which has to take care of such an individual. So the mobility getting restricted tends to hamper a lot of other comorbidities as well. So suppose an elderly patient is already diabetic and was advised to take a morning walk or do exercises, but unfortunately suffers a hip fracture, then that rehab, that necessary exercise which was required for control of diabetes, gets hampered. And therefore, the diabetes itself becomes uncontrolled. And the diabetes uncontrolled itself will cause other complications and uh, comorbidities. So it becomes like a vicious cycle. And therefore, it is imperative that we look at these hip fractures a little more closely and try and do our best to try and prevent them. So, what are these risk factors of somebody getting a hip fracture? Well, some of these are non modifiable. These include the genetics, that is, the race and the ethnicity. I cannot choose my parents at this point of time. Therefore, the genes are already in me, and therefore, I know what I am likely to have at the end of my uh, life or age as I cross 60 plus. If I already have a family history of a hip fracture, then I know that I am likely to be more susceptible to a hip fracture. A bone extreme obese individual is also prone to a hip fracture, as opposed to a low BMI patient also having a higher risk of hip fracture. Early menopause in women is also being associated as a risk factor. As opposed to this, there are certain modifiable risk factors. And this is where we can really come in and try and uh, prevent or make changes. So these include our diet, our lifestyle. Within lifestyle, smoking and alcohol consumption. In fact, the combination of both is more dangerous than in isolation. Proper exercise, and then measures to try and prevent the falls, and if so, how to do so. So if you look at the osteoporosis, what happens is with the bone age. Well, in an individual, the bone age, the bone density actually is very low at birth. But gradually, as one matures, till about 30 to 40, we tend to build up our bone mass. And after achieving a plateau sort of a level, it starts to gradually decrease. So one is for the male, one is for the females. And in female, after menopause, there tends to be a rapid decrease in the bone density, and it continues to go further and further down. The graph on the right actually depicts the number of fractures in blue in comparison with the bone density. So this is the bone density as measured on a machine, and as it goes more towards the minus side, you see that the fractures, the percentage of the fractures keep on rising. So that means as the bone density becomes weaker and weaker, the risk of fractures becomes higher and higher. Therefore, it is prudent to try and maintain our bone density at the higher level as much as we can. So, what are some of the other risk factors? Certain pre existing diseases or other diseases can also contribute to osteoporosis. Certain drugs can have side effects which contribute to osteoporosis. So, once if we are aware of these things, then we can try and tackle them accordingly. Are there any drugs to try and counter or rectify this situation? Well, yes, we have a lot of tablets. We have a group of drugs called bisphosphonates available both in tablets and injectable forms, which, given at proper intervals, can help to reduce the risk of fracture by maintaining the bone density. Along with that, a proper intake of calcium and vitamin D supplements, both of which help in the absorption of calcium and keep it in the bone so that it did not leach out from the bone. Some injections are also available nowadays, which can be given subcutaneously. Like any patient who takes insulin, it knows that the insulin is an injection and it has to be taken subcutaneously. Similar injections are available, which can actually increase the density of the bone and help in fracture healing. What are the lifestyle measures that we can take? Well, first and foremost, we can ensure that we have a balanced diet, which includes some amount of proteins, an adequate amount of calcium, which varies from about 700 to 1000 milligram per day as the recommended daily allowance. Different countries have slightly different exact values. That's why I've given a range of about 700 to 1000. I mean, the UK guidelines, the American guidelines, Australian guidelines vary marginally, but this is the average range. The vitamin D3 similarly varies in range from about 400 international units per day to about 600 to 800 in some studies. Adequate exposure to sunlight, approximately about half an hour per day before it gets too excessive, uh, helps the skin itself to prepare vitamin D, which is there in the cells. As regards exercises, well, a lot of core exercises, muscle strengthening exercises, weight bearing exercises help in prevention of osteoporosis. This fact has been proven, especially from our uh, astronauts who've traveled in space, where they found that because there was no gravity acting on them, they tended to develop osteoporosis. So now astronauts are mandatorily told to exercise every day while in orbit to try and prevent this weight loss. And finally, we can do regular checkups so that we know what is our base bone density level. This can be done by a simple bone density scan. It scans usually three areas of the body, especially those which are prone to fracture. So if a person falls down, then the fracture of the hip bone, the neck of the femur, or the trochanteric region of the femur tends to fracture. So both the femurs are scanned. The lumbar spine also tends to fracture, so that is screened, and the lower end of the radius. So as the person falls, to try and prevent the fall, the person falls on the hand or tries to block with the hand. And therefore the wrists, the region of the wrist, especially here, this tends to fracture. And that can be checked on the bone density scan. Similarly, in blood tests, we can check the calcium levels, the vitamin D levels, the alkaline phosphatase to know the turnover of the bone and what is the health of the bone. These can help us identify whether a person is osteoporotic, severely osteoporotic, non so, and accordingly, drug regimen, the diet regimen, etc., can be accordingly specified and tailored to the requirements of the particular individual. So, in conclusion, hip fractures can cause mortality and reduce the mobility of the individual. Prevention, as we always know, is always better than cure. There are the modifiable risk factors like diet, lifestyle, and we must try and aim at building a peak bone mass so that we have a good balance to start with. Everybody likes to have a good bank balance so that in post-retirement age we are self-sufficient. This is also like that. We should always aim to have a good peak bone mass so that by the time we reach our geriatric age, we are relatively safe, have a cushioned time, and are less prone to having a hip fracture. Thank you very much. We'll be able to take questions now.
Thank you, Dr. Anirban. Thanks for a very, very lucid presentation. I have certain queries. Now,
Yes.
As you said, prevention is better than cure. Now, you have experienced thousands of hip fractures and you have fixed it up. Now, you said then while you are fixing it, what is the timeline? When should the hip fracture be fixed? Suppose somebody is broken the femur, and elderly person, 60, 70, and 80, if you can break into three components, how soon will you like to fix it?
So, the earlier the better. Certain studies abroad have shown that if hip fractures are fixed within the first 48 hours to 72 hours, the outcomes are slightly better. However, there are often certain logistic issues involved. Sometimes a lot of these elderly patients are already on certain other medications, which sometimes preclude early surgery from point of view of anesthesia, etc. So what we generally do is we get our anesthetist involved with any hip fracture, let them clinically evaluate the patient, go through all the investigations, and once they say that the patient is optimized, then we go ahead and fix the fracture. In certain cases, it may be within a week. Rarely it has gone beyond 10 days. But in the last couple of years, because of COVID, I think a lot of our protocols had gone haywire. sometimes a patient became COVID positive and we were left with no choice because that took precedence over the hip fracture. So there have been certain lacunae, so to speak, but preferably we would wish to fix any hip fracture within the first week so that the further consequences of lying in bed, orthostatic pneumonia, etc., can be minimized and we can start the rehabilitation process at the earliest.
So what you are saying, what I'm hearing is that fix it as soon as possible. The earlier you fix the hip bone fracture, the sooner you mobilize them, sooner you make them stand on their feet. It doesn't matter how old they are. It's better for them, for their longevity, for their lying on the bed. They don't have to lie on the bed. As you said, if I have heard correctly, that the elderlies have diabetes and various other problems. If you make them lie on the bed, they get pneumonia, they get deep venous thrombosis, blood gets accumulated in their legs that leads to embolism and various complications. To avoid complications, it must be fixed early. That's what you're saying. Is that true?
Yes, sir. So complications are mainly related to the medical issues. The orthopedic related complications will be there with any orthopedic procedure. So yes, the bone is really soft, it is weak, it is difficult to sometimes fix them. But nowadays with newer technology, newer implants, most of the treatment strategies have been streamlined. The guidelines are more or less same. As you can see, there are not very many options. Either we fix them with some screws or with nails, with some plates, or we replace them. But the aim is that we try and improve the quality of life of the individual for as long as that person is alive thereafter. So the quality of life becomes more important rather than just saying that the fracture has healed, the bone has healed. The bone will take its own time to heal, which is a minimum of 6 weeks to 8 weeks. But in these 6 to 8 weeks, can we give the person a better quality of life? And that is important. So the mobility is most important.
So you're saying that we'll fix the bone. Bone is not a problem. That's something which you do every day. Medical wise, he has to be taken care of. Point taken.
Yes. Yes.
Now, Dr. Anirban, that everybody has a vitamin D deficiency. And whether he's a child, he's a grown up, he's a middle age, elderly, of course, have. And you have explained beautifully that at the age of 30, your bone mass is the maximum. After that, it starts depleting, bone become thinner and thinner, and you don't have to really fall. Even a small hit can break your hip bone. So can you explain that what leads to this vitamin D deficiency so commonly across the age groups?
I think one of the commonest attributed causes for vitamin D deficiency has been shown to be the modernization of our lifestyle per se, and the way most modern lifestyle, the entire day is usually confined to indoor activities as opposed to outdoor activities. So while we have grown on I would say on a scale where we are more successful. So we have right from an air-conditioned car to an air-conditioned office to an air-conditioned home, but inadvertently we have left out the exposure to sunlight, which uh, if it actually did reach our skin would actually make the vitamin D from the sunlight itself. So across the board, we now see, unfortunately, that vitamin D deficiency is quite common.
Yep. And you said that the modifiable causes are diet, exercise, lifestyle, cut down on smoking and alcohol. All doctors talk about smoking and alcohol intake. And if exercise regularly, and then you also said in modifiable, fall prevention. And you
Yes.
gave some example that those who have got a eye problem, they should have their glasses right. The bathrooms should be well lit and the floor should not be slippery. Can you elaborate that how to prevent floor from being more slippery? Because 90% of fall happen in the bathroom.
Right.
They all slip in the bathroom and fall. Either
Yes.
getting up from the pot or sitting on the pot or having shower or having just walked into the bathroom and just fall. So what could be the very commonest thing done at home which will prevent from elderly falling?
So it's a very, very valid question, and thank you for bringing it up. One of the commonest problems which we encounter is if you look at any house design nowadays, first and foremost, the access to the bathroom itself is small. Secondly, a lot of the bathroom flooring has now become tiles, which is usually the polished sort of a tile. But now, with increasing awareness, people are coming up with special tiles for the bathroom, which are slightly of a matte finish, which prevents slippering. The important thing is, in case those things cannot be done, a routine to be set up so that the floor is mopped every time somebody uses it to keep the floor dry so that the risk of anybody falling in the bathroom is reduced. That is one. For an elderly person, there also has to be adequate amount of light. An elderly person with a visual problem, uh, bathrooms often are not well illuminated at all places. So illumination in the is also an important thing. Then getting their eyesight regularly checked up. Thirdly, if a person has some gait abnormality, meaning a person in elderly patient may have a bit of dementia, may have a bit of Parkinsonism coming in, then they should use a walking aid, a stick or something for a support so that the risk of falling down is less. Similarly, in the bathroom, you can have some handles put up so that they can actually grab onto a handrail so that they can lift themselves up, or in the event of a fall, they have something to hold on to so that it can help to reduce the extent of the fall.
Absolutely. If I can add few more things from common sense wisdom, that whatever matte finish bathroom you have, but when the soap falls on it, it becomes slippery, even if it's matte finish. So probably the rubber mats, if you put across the bathroom, that would be probably much, much more safer. And don't have a step in. When you build a house, make sure that you keep in mind that one day you'll grow old. So the moment you have a step in the bathroom, you are stepping in and stepping out, you will fall. Eventually, you will slip. Few more tips that the lot of people tend to lean on the wash basin, especially when they are getting a reeling, or suppose they get up and brushing their teeth and getting a stroke or something, some discomfort. They lean on the wash basin, and wash basin falls, and they fall along with that and hurt themselves. We have seen hundreds of such occasions. So you need to ensure that your bathroom is very, very strongly put up for elderly. Elderly means anybody who's above 60, because you can have some problem in the morning, even if something as simple as you have urgency to pass urine and you go there in a hurry and slip, because all time you can't be careful. So you have to make your bathroom fall proof. That's for small wisdom from my side. Doc, one more thing I wanted to know, that
Yes.
you talked about osteoporosis, that where the bone mass decreases. Understandable. We understood that. Everybody knows that in ladies, their bones are thinner. Now, is there any food? Is there anything specific for elderly if they do, other than exercises which you have mentioned? Can there something more so that they stay healthier and they don't fall?
So in food, it is there have been studies which show that a good intake of calcium, an adequate intake of calcium and vitamin D, especially a combination of
Which food has calcium?
mainly dairy products. So milk and milk products are rich in calcium. Then we have our for non-vegetarians, fish, meat. They are all rich in calcium. Spinach is rich in calcium. So a lot of foods which are available which are rich in calcium. So these are the ones which need to be included definitely in the diet. Fruits automatically provide some amount of vitamin, not only vitamin C but also other vitamins as well. Vitamin D per se, again mainly going back to the non-vegetarian sources as well as mainly sunlight, and which is one of the reasons why vitamin D supplementation, if you find nowadays most pharmaceutical companies do not manufacture plain calcium. The calcium is always combined with some amount of vitamin D because that is required for the absorption of the calcium from the stomach or the intestine. So the role of vitamin D is quite linked to the absorption of calcium. So these two work together.
Dr. Anirban, I'd like to know about that. What is the hip joint replacement? How is it different? Where do you use hip joint replacement and where you just do the nailing? Can you just explain it a little more clearly in layman's term?
Right. So,
What are the advantages?
pardon me, sir?
What are the advantages of hip joint replacement?
Actually, the decision about whether to go in for a replacement or a fixation of the fracture depends a lot on the exact geometry of the fracture. So, if I just go back to my first slide, I'll just explain that. Yeah. So, if this is the normal hip joint, this is a type of a fracture. This is fracture which has happened at the trochanteric region. So this is the greater trochanter. So this is a fracture which is essentially outside the capsule of the hip joint. As opposed to this fracture, this is happening inside the capsule of the hip joint. It's actually a fracture through the neck. Now these are the fractures where the blood circulation of this head tends to get disrupted, and therefore the viability of this head becomes questionable after a hip fracture. And so retaining this hip fracture, this head, and trying to fix it with all sorts of plates, screws, or nails is often not really helpful in the long term. So these are the fractures where we would primarily go in for a replacement, meaning we remove this part of the head of the femur and we replace it with a new a prosthesis, a ball and a socket. We may replace only this part of it, where it is a partial hip replacement, which is also called a hemi replacement. And in case the other side, the socket of the head is also damaged, which we may see intra-op, it may not be decided pre-operatively. Intraoperatively, if we find that the socket is also damaged, may not be able to sustain the weight of the prosthesis, then that also is changed and that becomes a total hip replacement.
What is the longevity of hip joint? A new hip joint which you put in somebody who's 60-year-old.
So most, even the cemented varieties which we used, they last for at least 25 to 30 years with current generation cementing techniques and technology. So a person undergoing a hip replacement surgery at 60, we expect it to last for the entire life. In case it is slightly earlier, then the person may require change of the prosthesis at a later date, closer to 80 or something. But then depending on the quality of life, the demand of the individual on the particular hip and the associated comorbidities at that point of time. If the person is fit enough to undergo a revision surgery, then only. Otherwise, if it is not causing any problem, then we can continue with the same.
So if I have understood correctly, Dr. Anirban, you are saying every fractured hip has to be handled, has to be intervened orthopedically, it has to be changed or fixed. There's no joint which can be left alone, and every joint has to be fixed so person can be made mobile immediately. Is that okay? It's the right statement to make?
So every statement comes with terms and conditions apply. So there are a very small subset of fractures which may say involve only say the tip of the bone here or a small crack in the pubic bone here, which are not amenable, do not require any surgery. Those are the only ones where we would recommend that, okay, let the person just be on bed rest for a couple of weeks. Once the pain of the fracture subsides and the fracture union process starts, we can start them a little bit of supervised mobilization. So meaning not get them to start weight bearing immediately, but at least start sitting up in bed a little, start rolling in bed. So the chances of the other complications which I had mentioned can be minimized.
So if I'm hearing it correctly, what you're saying, that if it is not weight bearing fracture, if the weight is not carried through those bones which are broken, then you need not really go and change it immediately. But wherever it is a weight bearing they have to be handled on priority. Is it right statement?
Yeah, that
Good.
is the right
Thank you.
statement. Most, in
Yes.
fact, 90% of the hip fractures are either fractures of the neck of the femur or in the trochanteric region. And these are the ones which are essentially unstable per se and definitely require some sort of fixation. It's a very small percentage which do not require any operative intervention and can be managed conservatively or non-operatively.
Actually, your statistics which you presented somewhere that though the hip fractures are only 20% of all the fractures, but they're almost 60% of the cost. That means and also they lead to huge mortality if not fixed in time.
In time.
So that's very clearly demonstrated. Doc, what is the right unit of vitamin D orally every day?
You currently recommend between 400 to 800 international units per day. On the basis of a vitamin D report, we can classify a patient as being sufficient, insufficient, or deficient. Those who are insufficient or definitely deficient, then one method of advocacy is to give them a weekly dose of vitamin D at about 60,000 units for about 6 to 8 weeks, and then move to a maintenance phase of once a month for another 6 months to 8 months. So that is the requirement from the deficient or the insufficient ones. Those who are borderline ones, they can be given a simple 400 international units per day.
So you are saying that they're graded requirements. Somebody needs 60,000 per month. Somebody could need 60,000 per week, or somebody could take 400 per day, depending on the level of osteoporosis or vitamin D deficiency they have. Is that right statement to make?
Yeah, that is right. And we also have tablets in 2000 international unit strength as well. For the pediatric age group, there are drops available in which up to 1000 units per day can be titrated.
Thank you, Dr. Anirban. It was most enlightening. And I'm sure all my listeners will agree that you really presented it very lucidly and explained in a very layman's term. So friends, Dr. Anirban Chatterjee is saying that the most of the time the hip joint falls apart because of trauma, because of the home accidents, maximum the bathrooms, and it is preventable. It's preventable if you are cautious, if you are aware of. As we read, Tamso Ma Jyotirgamya, lead us from the darkness to the light. So you truly have to have light in the bathroom. If you have a light and if you have a different grips for them to hold on to, and you make things stronger, avoid steps, don't make the floor slippery, you would save a lot of your elders from falling sick, because it's expensive procedure. And it has to be done. You can't avoid it, can't sit over it. So sooner you fix it, better it is, because it certainly leads to the better outcome, better quality of life if it gets fixed early. He also cautioned us that out of 100,000, 1 lakh people population, 1,500 lead to the hip fracture. It's a huge number. It's a huge number. So he says diet, lifestyle is useful. If you modify it, you can't change your parents, you can't change your bones, you can't change history of disease in your parents, but you can change your lifestyle. Exercise regularly. If you exercise regularly, and he's shown exercise, very simple exercise, stand behind the chair and tiptoe. He has explained so clearly that a simple leg raising on both sides. He has said that just lifting yourself up and low, stabilizing your core will give you strong bones, and strong bones will not fall. And he said that the mild trauma, that most of the time, these elderly don't have a severe trauma, they don't have a road traffic accident. It all happens. I know a lady who broke her hip joint just by, she kicked the door to open it, and she broke her bone and she died. I know thousands of such cases in our lives. And small precautions, small caring, small exercise can keep you healthy and can keep you going for a long time. We want our elders to survive, to live long, so they can guide us more. They lead us from darkness to the light. With this, I am extremely thankful to Bengal Chamber of Commerce for associating with us and Rotary Club of Calcutta, Aviana, for taking us to their members. Thanks to all of you. A very happy Saraswati Puja, and stay with us every Saturday, 5:30 to 6:30. We'll bring you new things to keep you healthy. We want from Medica, from the bottom of our heart, we want you to stay healthy. We want to move from illness to wellness. This webinar series is one step in the direction. Have a nice weekend. Happy Saraswati Puja again. Namaskar.
Thank you. Thank you all.
Thank you.